The next person presenting is Shariq Mohammad. Is there a difference in compliance between pharmaceutical, non-pharmaceutical, and other treatments in adolescent patients with ADHD? And what interventions may be used to increase patient compliance?
Hello, everyone. I'd like to thank you for being here, and then I'd like to thank Dr. Talley for being my mentor on this project. So my project is on effective interventions to increase treatment regimens for adherence for adolescents who have ADHD. So just a quick definition of ADHD over here. From US adolescents 12 through 17 years old, there's 2.9 million adolescents who currently have ADHD. Of these, 62.1%, 1.8 million are being currently treated with medications. So at a rate of using a 5% rate of diagnosis, the estimated cost in 2005 was $42 billion, which is a large magnitude of a problem. So I think this is also related to social determinants of health. So this is just a quick definition of social determinants of health by the World Health Organization. So it's the conditions in which people grow, live, and work, which also affects their health outcomes. So there's some social determinants of health over here that will be affecting adolescent health. And then one example that we found was adequate prenatal nutrition will reduce the rate of preterm births, which is something that's associated with ADHD occurrence. So just a quick method section of what we did over here. First, we were trying to acquire articles by organizing a search, and then we went through several iterations of trying to filter the search in order to try to find the best information from articles that are very relevant to our search. So this is the way that we organized our search. We used these primary search terms listed above, and then we had some restrictions on them, for example, being published before 2021, and also having them be systematic reviews, randomized control trials, or meta-analyses. And the reason we did that was in order to get data that's been through the vetting process of a randomized control trial and of the review process. And this is the focus statement that we had when we were looking at this data in order to identify the best data. We used 6 databases and found 731 articles. And then this is a quick summary of what we did for including or excluding certain data. Over here, this is our quick process of how we filtered the data in order to use 2 graders to try to come and independently grade a paper. And if they disputed, then you send it to a 3rd grader in order to assess whether to include or exclude that data. So this is a quick Prisma form of what we did. As you can see, we started out with 731 records, 731 articles, and we ended with 7. So there were a lot of articles that were excluded for various reasons. So quick results slide. This is a summary of our findings. You can see that we had a lot of different factors that we were tracking to try to see what factors were best relating treatment outcomes, so adherence, to any factor that could have been part of a demographic factor, or what medication they were using, what therapy they were using, any comorbid conditions, in order to try to find a good factor. So these were the results that we found as well, going through the different authors that we used, interventions, results, and then also symptom records. We also assessed these articles for bias in order to see benefit or harm bias as well, using the Orbit's bias chart. And then I just have some key findings and some discussion points as well. So one is that oral release methylphenidate is more effective in maintaining optimal adherence, and instant release, extended release methylphenidate is more effective in maintaining suboptimal adherence and starting adherence from a state of non-adherence. So the reason this might be so is that routine is very important for ADHD adolescents in order to take their medication. And due to instant release, extended releases, twice a day dosing mechanism, it gives adolescents 2 chances instead of 1 to demonstrate and practice adherence to their medication, which is very key. Another one that we found was that the choice of taking different medications, where here it's osmotic, oral release osmotic methylphenidate, instant release, extended release methylphenidate, or atomoxetine, doesn't have a predictable value in the improvement in symptomology scores. And also there is a presence of consistent symptomology evaluation scores across different treatment groups, control groups, and different types of therapy across 3 of our studies. The oral release methylphenidate and cognitive behavioral therapy and the placebo and therapy also have similar improvements in ADHD scores, along with different therapies having statistically similar improvements. There are a few possibilities here, over here, but the key slide is that social determinants of health may be examined as a possible unknown factor for treatment adherence rates for adolescent ADHD patients. So screening for this could be effective in finding good interventions in order to mitigate this factor. We had some limitations with trying to measure treatment adherence. We had some limitations in trying to find a way to compare these studies. So we recommend having a study to focus on developing a measurement tool. And also aggregating of adolescent data was a limitation that we faced. So this is a reference list over here. And thank you for coming. Any questions?